Good afternoon, everybody, and welcome to the 40th episode of the RSM's COVID-19 series, which is for health professionals, by health professionals, as you can see there, and designed to give workers on the front lines regular updates from healthcare leaders on COVID-19. And just to say, there is a Q&A feature that you can use if you want to ask questions during the session, and we're going to leave about 20 minutes at the end. Should you want to ask any questions. You can also upvote for the questions you would like to be answered by our panel. So this is back to school, infection, risk and mental health, which is such a vast area. I don't think we're going to get back to, we're going to get it through it all in 45 minutes. But we will be looking at some of the evidence surrounding infection in schools, the plans in place to mitigate any risks and how the reopening might influence further spikes to the virus. And the panel of two will cover the mental health impact as well of the pandemic on children and young people, the size of the potential problem and how we should monitor and assist in dealing with these issues. I'm racing through this because we have so much to get through, but I want to introduce our panel, Amanda Spielman, who is Chief Inspector of Ofsted, and Russell Viner, who is President of the Royal College of Paediatrics and Child Health. So welcome to you both. And thank you very much for taking part in this. Just to say, I think I've already warned the panel that we have already had 41 questions. There's a lot of interest in what you two have got to say, not to make you nervous or put you under any pressure. I want to start immediately with you, Russell. If you can explain, and I'm interested in this myself, not only as health editor, but also as the parent who dropped her daughter for her first day at secondary school this morning. And I've just wiped the tears from my eyes just now. The evidence we have seen, as you have repeatedly said, there is that the infection rates are low amongst children, but there is a differentiation in the ages. And I just wondered if you could explain some of that.
Absolutely. So what we know is that this infection, SARS-CoV-2, which causes COVID-19, seems to behave very differently to past pandemics and seems to affect children in very different ways. So clinical case series tell us that children and young people make up only a tiny proportion of actually the cases we identify with having COVID-19. And that's in terms of people who have positive tests, those who get severely ill, and those who die. And in fact, children make up a smaller proportion of each of those. And in fact, if we talk about deaths, and it's really difficult to talk about deaths because the death of any child is one too many, we simply compare potentially around 15 to 20 deaths of children and young people with COVID to over 40,000 in adults. And that just tells us the differential. And we know many more children have died during the pandemic of other causes and injuries, and even suicide, than died with COVID-19. But one of the issues is that those clinical case series really underestimate the number of children there are with COVID because children are generally asymptomatic. So it's been really complex to understand how children are affected. And I think one of the problems is we see a different study come out each week. It gets talked about in the media and talked about by scientists, and actually each of them only gives us a very small part of the jigsaw. And sorry to go on at length, but I think there's three key questions to ask. Firstly, do they catch it, children and young people? Secondly, how severely do they get it? And thirdly, do they pass it on? The first one, do they catch it? It's important because you can't pass it on unless you catch it. And actually the evidence suggests that children under 10 to 12 seem to be about 60% as likely to catch it as adults. So about a 40% reduced risk. Evidence for teenagers is much less around, but actually teenagers seem to be able to get this infection as much as adults. And we know that young adults, 20 plus, are getting it, in quite large numbers at the moment. That's getting it. When they get it, they get incredibly mild illness. They're very unlikely to get severely ill and extremely unlikely to die, much more likely to die from suicide or car accidents, or people have even talked about lightning strikes. I don't know exact the detail on that. The third question is, do they pass it on? And one of the interesting things here is you will see papers on viral load, on nasal swabs, and all sorts of technical scientific studies on children. But the only true measures of whether they pass it on is whether real children in real life situations pass it on to other children or to adults. And the data from around the world, when schools are open, because we have an increasing amount of data now from when schools are open, tell us that children play a very limited role in this pandemic. Children are human beings, of course they transmit this virus, but they don't do it very well. And the interesting thing about schools, and I will stop now, we build schools to transmit ideas. That's what they're there for. And they're really good at that. Sometimes they transmit ideas we don't particularly want, such as radicalization, and we know how to control that. We've always known that schools are good at transmitting bugs. Lice runs through schools, impetigo, all of those things. And that's one of the reasons we think about schools as being good at transmitting COVID. But the truth is, from the evidence we have from multiple countries around the world, is that the schools are not places that transmit COVID particularly well. I'll stop there.
I think the issue there, Amanda, is of course it is trying to calm some of parents' fears, calm teachers' fears. With some of the information we have, the ability to educate people about risk, at the same time getting children back to school. How well do you think schools are going to deal with this? How do you think they're going to cope with this fine balance of keeping children and teachers safe and yet getting children the education that they've now missed out on?
You're right that this is a really fine balance and a challenge for schools. I think most have been working really hard, really conscientiously to set up the arrangements at the various pieces of guidance, tell them they need to be running from this week onwards. From what I can see, that prep work is by and large being done really thoroughly and conscientiously. But of course, it makes an experience, firstly, which of itself can be a little bit anxiety inducing. And beyond that, it's very clear that a lot of teachers and a lot of parents have become very afraid. And perhaps, particularly in relation to children themselves, as Russell has illustrated, perhaps slightly out of proportion to the actual level of fear that should be experienced. So I think there's a crucial management responsibility for all the adults involved here, parents and teachers, to make sure that they don't let their own anxiety transmit itself unnecessarily to children. Perhaps a couple of contrasting stories here might illustrate that. A few months ago, I was in a primary school where the head, going around the year sixes, tapped all of them on the shoulder. So feeling good, it was 3 months before the primary test, the SATs. Feeling good about your SATs, not worrying about SATs, are you? Looking forward to the trip after SATs? And I thought, if they go around doing that every day, every week for several months, my goodness, those children are going to be scared out of their wits about it. Something that superficially looked as though it was intended to provide reassurance was probably actually generating fear and anxiety in those children. One of my favorite examples the other way is from a children's book, When Hitler Stole Pink Rabbit, if anybody's read it, where the author was 6 or 7 when her parents managed to flee Nazi Germany before the day her father was going to be arrested. And it conveys the extent to which those parents, and I'm sure many thousands or millions of parents like them, went to make sure that their anxiety and fear didn't communicate it to their children and undermine the children's own happiness and stability in their lives. It's such an important thing, I think, for everybody to recognize that completely by accident, in these slightly odd circumstances, we could potentially actually transmit anxiety that we shouldn't be transferring to children.
I'm going to come back on to mental health, which is very much part of this discussion, but I just want to ask you some slightly more practical questions, and we've had some questions already come up on this about one is children at greater risk of catching measles than COVID, but which I'll come back to you, Russell, on that. But just, Amanda, while I've got you here, do you think that all schools have been adequately equipped to deal with infection control measures? I think that's very important. A lot of parents will be wondering about that. Things like peripatetic teachers and therapists coming in each day. We had a question about mask poverty, about pupils being able to afford masks? I mean, there are so many practical questions. How well do you think schools are going to cope?
Well, I think it's really important to recognise that schools are run in a very different way from the health system. This is not a monolithic system run from the centre of government. Schools are high autonomy institutions by comparison. Many of them are in multi-academy trusts, where it is very clearly that legal entity that has the primary responsibility. Some of them are run through local authorities. It is not the Department of Education that's sitting directly controlling each school and saying, here's your allocation of this, here's your allocation of that. It is in some ways a simpler system, in some ways a more complex system. I think the process that we've been through over the last few months in trying to get to the right level of guidance for schools to make sure that they properly understand what they need to do, but also have enough flexibility to adapt to circumstances. Schools have very different building sites. Some of them have children with very particular special needs, others don't. There's a sort of damned if you do, damned if you don't factor that if it's not specific enough, people will complain that you haven't given them enough guidelines. And if you have too much, they complain that it's too specific and you're not trusting them to act in the interest of children. It's always a delicate line for government to walk to get the guidance right. So from what I can see, most schools believe that they're fully prepared and opening responsibly. Ofsted is going to be doing a series of school visits through the autumn. We're not doing full inspections, but we are going back around doing a programme of visits. And of course, the leadership and management piece of our inspections is very much looking at whether school leaders are acting responsibly, understand what they should be doing, and equipped to do that. So it's not item by item compliance. There is nobody from outside the school staff moving through the schools to check every microscopic detail against a checklist any more than we do that in relation to all the other sort of hundreds and thousands of legal provisions that apply to every school. There is an extent to which this functions out of expecting people to take responsibility and sort of scrutinising periodically, but not micromanaging them.
Yes, and I suppose I hope making sort of sensible and logical decisions that about what's best for their school. Can I come back to you, Russell? There are some very interesting questions again coming up on this about, and particularly about spikes in the community. And there are some people who are asking quite legitimately, is although the children might not be getting ill, they might be asymptomatic. But what about if they're going home to their over 70-year-old grandparent or something like that? And also, if I can get to add on to this spikes in the community, because that's what we're all looking for, to see if there will be any spikes now that schools have gone back.
Sure. Much of this, I very much understand the anxiety, and particularly from families where grandparents or parents are clinically vulnerable, may have been shielding. And this is also a particular issue, I know, for lots of multi-generational families from a BAME heritage. I think we need to, one of my perspectives, I think, is there's so much theory that drives us on COVID. And of course, children theoretically can do all of those things, and we should be concerned about that, but we have to keep going back to what the data tell us. And everywhere this has been studied, this is including in households. So there's been a lot of household studies initially coming out of China and coming from elsewhere. And then more recently, studies in the community when schools are open. They tell us that children do transmit to adults, of course they do, but actually at a low level. So within household studies, for example, when people have looked at household outbreak studies, children appeared to be the potential index case, the case that brought it in 10% or less of those cases. So it does occur, but it's really quite uncommon. When we looked at outbreaks in schools, so looking at the transmission from children to other children and from children to staff, actually studies in Australia, studies in Belgium, studies in Singapore and Ireland and a number of other places actually find very, very little evidence of that. Where we have evidence of transmission, it's usually from teachers bringing infection into schools and often spreading to other teachers. Of course, there is some transmission from children to adults, but really very, very, very unlikely. I think it takes us back to issues of what is safe and what is a tolerable level of risk. And I think we absolutely need to talk about that early on. If we wanted everything to be perfectly safe, we would never open anything. None of us would ever go out of our front doors, because every time you go out of your front door, you start to accumulate risk. You cross a street, you go to work, you get in a car, you're starting to be unsafe. And there's a level of risk to all of those things. I think here it's about balance of risks for me. And it's trying to separate out the balance of risks for children and for adults, and then for the broader population. For children and young people themselves, I think the balance of risks is overwhelmingly about being in schools. For our society and the broader population, I think the balance of risks is again very clearly that way. The impact that schools will have on the broader population it appears not to be very great. Reopening schools appears to be one of the safest things that we can do as a society. Clearly, the safest thing to do would be to shut down society forever until there's a vaccine.
Do you think, Russell, then schools should not have been closed down at all? I mean, do you think they should have stayed open? Did we close them down too soon and for too long?
One of the things this country did was aim to close schools relatively late. And actually, if we go back to when schools were closed, part of the reason they were closed was that they were being closed by parents withdrawing their children from school. I think that's one observation. The second observation is, I think when your back's against a wall, when you're facing a pandemic that you know almost nothing about, I think it's very logical to pull out every single arrow in your armamentarium. And closing schools is one of those arrows. I think our point is it should be a very late thing to do if we do it at all. Other countries have shown us that you can get away with not doing it at all. And it's about balancing the risks and the harms. So that's what I wanted to come back to. Can I come back to I talked about the risk balance for children and young people, for broader society, for parents and other adults. Clearly, children can be asymptomatic. Children can be infectious. Clearly, they can carry risk to adults. There's no pretense that they do not. The truth is that appears to be one of the least common ways that adults get infected. I think if there are highly vulnerable, clinically shielding grandparents and others, that actually full-on hugging and kissing your grandchildren after they come back from school may not be the most sensible way to behave. We don't believe in cutting off all physical contact between children and grandparents, but actually, a lot of kissing and that kind of thing might not be the most sensible thing to do. Keeping children seeing grandparents is important, making sure they wash their hands, etc. when they come back from school. Being sensible, being relatively secure, I think is the way forward.
Amanda, can I just come back? It's a slightly more practical question again on this, but where do you stand on the idea of systematic testing and what we should be doing for testing teachers? What do you do if a child starts coughing in the class and a teacher has to send them home? Should schools keep swab tests to send home with them? What should happen?
Well, it's something I have to be really careful about is not second guessing public health guidance, because I am not a clinician and I should never say anything that implies I think that I have that authority. But broadly, my sense is that the framework of guidance that's been created is a pretty cautious one. To Russell's point, there is no absolute safety in life, or you can create absolute safety from one thing, but incur a ton of downsides and risks in other ways if you do that. The kind of evidence that he's quoting, I have to say, I find pretty persuasive. Something that people don't often remark on is that actually schools and colleges create, if we think about this as being a risk that is greatest for adults, and as between adults, of course, schools are places where social distancing happens by default. In the main, you've got a teacher in one classroom, a teacher in another. It's only in sort of break times in the staff room that you actually have teachers converging on each other and tending to interact the way other people might normally interact in an office. I've not seen people talking about that natural spacing out effect, which might perhaps be one of the reasons why in the places where schools have stayed open, that there've been relatively few outbreaks.
Can I come in on
one more thing before coming back, Russell? I sometimes remind myself when people cite cases of schools where there have been some cases, that it remains a very, very small proportion of the 20,000 odd schools in the country, as far as I know. And there's if one or two schools have to close for a period because there've been several cases, that still probably means many thousands of schools and millions of children in those who are continuing in education. So we constantly have to weigh up this difficult balance.
Just speaking to the point you made, Amanda, I think it's really interesting. There may, and this is conjecture, I don't have evidence for this, but actually, given that we have evidence that children under 12 may be less susceptible or are less susceptible, we think that's, pretty good evidence. Nothing in this pandemic is really secure evidence yet, but we think that's the best evidence we have. Children under 12 appear 40% less susceptible. Teenagers don't. Yet what we don't see is a lot of transmission from teenagers through schools. And it may be that there's something about schools that's slightly protective. We are starting to see higher numbers of COVID cases in particularly 20 to 29-year-olds. Interestingly, South Korea saw this first at a time when we were seeing cases in the elderly and others. And I think a lot of us found it very puzzling, but we're now starting to see this in the UK and the USA and others. And it may be something about social contact patterns amongst young people, but mostly out of school. And there may be something about the school scenario that's relatively protective here, but that I would say is conjecture.
It's conjecture, but it might create an interesting rationale that if you can satisfy young people's need for social interaction in the relatively structured environment of school, you might see less risk-taking behaviour outside school, where there are fewer constraints on their behaviour.
Interesting, yeah.
And talking about risk-taking and behaviour and so on, I wanted to move on to, actually I'm not sure if that was a great segue or not, but I wanted to move on to mental health. And partly what my thinking was, we were discussing before this began, the idea about the emphasis and concerns about the impact of COVID on mental health on children. And I wanted to put to both of you, both this question of how do we know for sure, because I've read a lot of conflicting reports on whether children have suffered during this lockdown. And then if I can put that to you, Russell, and then Amanda, it would be very interesting to know if you feel that schools are equipped to be able to deal with any anxiety or mental health issues that have come out of that. But Russell, what do you think the evidence is?
So look, it's a really good question. I think there's absolutely, definitely evidence that children and young people have been harmed during lockdown. In fact, when I talk to people about COVID-19 and children, I use the term collateral damage, which is that there's very little direct impact of this infection on children in terms of severe illness and deaths, but the impacts we see on the great majority of children are essentially the collateral damage impacts on mental health and well-being, on learning, obviously, also on obesity, on sleep, a whole range of things. Specifically on mental health, there is a little bit of conflicting evidence, but I think overall, the evidence should make us quite concerned. Let's start with in a sense, the nuclear option. Death by suicide of young people is probably one of the most tragic things that happens in our society. And there are small numbers of young people that take their own life every year in this and all other countries. We're lucky enough, we're the only country in the world that has a statutory requirement to report children's deaths under 18 within 48 hours. And reports from the National Child Mortality Database tell us that there had been a 40% increase in suicides by teenagers during lockdown. Now, the numbers are always small, 1 to 2 per week in general is the background rate. So this increase is not statistically significant, but as a researcher, you know, I've learned to be very suspicious of statistical significance at times. I think that's a clear signal. And so there's about 25 young people took their life. And in about, I think half of those, 12, there was clear evidence from the data collected that the lockdown, the school closures, etc., played a role in that. So that is a particular concern. There's good evidence across the whole population that well-being and mental health has got poorer in adults because we have better data on 16 to 18 pluses. And in fact, if you look at those populations from 16 to 18 plus up to the elderly, the group whose mental health has worsened most have been the 16 to 24-year-olds. And I'd remind us all that it's the 16 to 24-year-olds that have suffered the most in terms of economic losses from this pandemic. They're the ones with the most insecure employment. In terms of direct measures of mental health, we're very good at measuring that in adults. We don't have robust national level data on this yet in children. That's been funded and hopefully will be out in a month or two, but it's poor that we don't have that on under 18-year-olds. However, the data we have suggests that there's definite evidence of, in younger children, of higher levels of emotional problems and anxiety, etc. And I think amongst teenagers, we have a little bit of slightly conflicting data. Some studies showing clear evidence of higher anxiety related to the pandemic, related to not being in school, related to missing friends, the issues related to isolation, but a couple of studies suggesting that there are groups of children who actually have less anxiety when they're off school during the pandemic. How do we make sense of that? The answer is there's no one bit of mental health for all of us. I think at a population level, this has clearly caused harm to children and young people, but there will be some who actually have not been harmed by this.
Well, given, Amanda, the Russell's view that there is clear harm in some cases, of course, that some children have been fine, but how well do you think schools are going to be able to cope with what they may be coming across, with dealing with these children who are going back this week?
First of all, I agree with Russell that there have been some significant harms, and unfortunately, one of the things we do is inspect children's social care provision as well as schools, and we've seen some clear evidence of more bad things happening to children who have been essentially removed from the normal lines of sight that would pick up some of the things that go wrong for them. So sad but true. I also think we've got some really interesting evidence from the many schools. Nearly all schools actually reopened to some extent in June, not to the whole school, but at least partially. And at this stage, this is anecdotal. I'll be able to talk about it more probably by the end of this year when we've done our autumn cycle of visits. But anecdotally, many schools had assumed that children's mental health and well-being would take an immense amount of work, and they'd have to put in a lot of time early on to sort of stabilise children, restore normality. And then what came out were a series of anecdotes like, we had a whole week of wellbeing lessons planned, but by lesson 3, the kids were saying, please, miss, can we just go back to reading Holes? We were reading that when school stopped. So children themselves begging for normality. And I think that the good news that schools seem to be reporting out of that is that for the vast majority of children, the simple restoration of normality was all they needed. And that doing that helps make clear who are the small proportion of children who genuinely have got things going wrong in their lives for whatever reason, who do need that urgent help, who maybe should have been getting help all the way through. We know, for example, that provision for special educational needs children has been much worsened through lockdown. There are many very unhappy parents there. But so it's important that how schools operate now doesn't inadvertently encourage children who are actually going to be, who may have been quite unhappy, but who are going to be just fine with normal school, normal levels of contact with their friends resuming, from thinking of themselves as sort of damaged, in need of support, in needing to suck in scarce medical resource of various kinds. So that top priority for me is making sure that the way schools operate from now onwards does as much as possible to reinstate normality. And of course, I'm aware that for some people that creates a difficult trade-off with the most extreme sort of levels of medical precautions that they could potentially take. And it does necessitate some difficult choices. But I think we must remember that actually in children's interests, making sure that we don't make schools sort of by default feel like intensive care wards does matter.
It's hard to remind ourselves that we are not very long into this pandemic, and that there are still a lot of unknowns in this. But we have heard a lot about the impact on mental health, and there is talk about setting up new psychiatric services in schools. Is this too much? Do the schools need it? Should that money, should those services be directed somewhere else?
The important point always is not for schools to become providers of mental health services themselves. Teachers are not clinicians. Teachers are good at educating. Teachers are good at teaching. Teachers are good at the sort of first level of pastoral care for their children, but nobody should be pushing them into being amateur sort of mental health experts. What is needed is the right interfaces to get help where it's needed and to get it swiftly enough where it's needed. It's always a challenge making sure that the people on both sides of that understand and have good enough working relationships to make that work as well as it should. COVID and the lockdown of schools has undoubtedly disrupted that. It's one of the reasons for me why having schools as close to normal functioning as possible really matters, because we can make sure that crucial education healthcare interface works as well as it should, but respecting people's different expertise and roles throughout.
We were talking too earlier about that, the discussion around mental health, but we need to talk about physical health as well. And I certainly know from my own daughter that when she couldn't go out and do her normal physical activity, she became quite difficult to deal with. I hope she doesn't see this back in 10 years' time. And one of the questions that has come up, for instance, is how do schools get back to making sure they're doing after school sports events, that they're playing netball, football, rugby, and so on, when there's still degrees of concern over contact.
You're right. People are seem to be paying far more attention to mental health than to physical, which I find quite odd, given the importance of physical activity for children's well-being. I've noticed very little actual talk about recovering children's physical health compared to the amount I've seen about recovering their mental health. And I'd like to do what I can from where I sit to keep reminding people that the physical is important. Again, I think there's a huge range in what we see in schools, and it comes back to this level of autonomy that schools have to decide what they offer. I think there are schools that are already being really imaginative and enterprising around what they offer, and saying, okay, so some of the things that we normally do on the exercise front don't fit so well with this infection control regime that we're trying to operate, but these alternatives do. And of course, from what we do know, being outside of itself is probably a good thing in terms of risk reduction. So I'm hoping that perhaps lots of schools will feel positively enthusiastic about getting children outside to exercise as much as possible.
There are so many questions coming through, and I have asked some of them as we've been going along. But Russell, I just wanted to come back to you, and it is you picture yourself, you're the teacher standing up there in front of the class, and some of the kids start coughing because it's winter and because that's what kids do. How are you able to assess for yourself as a teacher that this isn't COVID, that you don't need to close the whole classroom down, because you just simply can't do that for every time a child coughs?
Absolutely. And of course, coughing is normal. I almost coughed before, but let's go back to the symptoms of COVID. And at the moment, we think they largely apply to children. We need to do some more work on this. I absolutely understand the issues here. And we've been talking to government and DFE about the fact that, you know, ordinary healthy children will often get a fever every 2 to 6 weeks over the winter. And they're usually coughs and colds. It tends to come with rhinorrhea, a runny nose, much more rarely a cough. The symptoms of COVID, I think, are relatively clear about a persistent new cough, about high fevers, etc., etc. There's some other symptoms such as the anosmia, which is much rarer in children, that does occur. Whereas coughs and colds in children tend to be a bit of a cough, not necessarily a persistent cough, a fever, rhinorrhea. The approach to this, I think, is complex. We absolutely recognize that simple rhinorrhea or a runny nose is very unlikely to be COVID, though I think we need more research on that. And again, a child with a bit of a cough. For a teacher, and you asked me to think about being in a room with a child there, I think we need to recognize that teachers have been in that situation many times, that influenza can be bad. Influenza is something that we're used to dealing with every winter. I know this is a different pandemic. I absolutely don't claim they're the same thing. But I think that recognizing there is some distinction in symptoms between a persistent cough with fever in a child compared to a child coughing in class. And actually, if the teacher is socially distancing, is further away from the child, there's very little evidence that there's a risk of transmission there.
Sorry, just while I've got you here too, I just want to quickly go back to the mental health issue. What is some of this, all of this is really, I suspect, quite observational, but what is the evidence that a lot of the anxiety is being driven by the parents rather than the children themselves? Do you think there is some intervention in some ways, something that needs to be done to reassure the parents rather than the children?
I think it's really important not to get into parent blaming in a sense, but just recognize that, you know, parents are much more aware of the facts. They watch the news much more avidly. They, you know, have so much more lived experience. They can imagine the issues and the dangers. And it's very natural for parents to be so concerned about their children. So I think that parental anxiety is very normal, and it's an increasing part of our modern society in a number of ways. So I don't think we should see that as parents creating this. We should just recognize, my personal view is the most important thing we can do for our children and young people's mental health is to get them back to school. And that's a very public mental health approach. We need to, and Amanda talked about normality, and I absolutely concur with that. We have too many young people who have clinical grade mental health problems in this country. We absolutely do. There's evidence that they are the most likely to have been impacted by lockdown. So we may expect to see some of those with more concerns when they come back to school. We know, sadly, that a number of children and young people have found it difficult to access mental health treatment. So it's the group that were already in the clinical zone, in a sense, that may struggle most. But at a population level, the most important thing we can do for them is to get them back to school in a sense of normality. And that's where, you know, these issues are so difficult. You know, the question before about the teacher and the child with a cough. If the teacher reacts with panic, if the child is sent home for coughing, or the child is somehow made to feel abnormal, or et cetera, you start to feed into the anxiety. And the way that the school reacts to that can start setting up all of those anxieties, which, as I said, if we go back 2 steps and look at the real evidence, not necessarily, biological studies of viral loads in people's noses, which are very important, but they don't tell us actually about transmission.
So we are inevitably starting to run out of time, but I just want to ask you, Amanda, a question that came up is what training is Ofsted giving its inspectors who will never themselves have directly had to deal with a pandemic? Well, for many of us, but specifically the inspectors.
Well, our inspectors are getting their training this week for these autumn visits. Actually, I've had quite a few of them on secondment to the Department of Health, setting up delivery of various testing systems. So a surprising number of them have been deeply involved in COVID specific work. Another 150 at local authorities similarly. But of course it's important they're well prepared, and so they need the same understanding of the guidance that schools and colleges have, and of course they need to make sure that any institution they're visiting that they're working within the guidance as that's been implemented in that particular institution. It would be hugely disruptive if they worked any other way. But we always put a great deal of training into inspectors for that reason. It's important that that they make a real contribution, that they don't disrupt any institution they visit, that in the medium and longer term they contribute to it. So it's something that's mattered a lot for me to get right. But it's also important for me to be clear that our inspectors are not health and safety inspectors doing sort of full compliance checks on this COVID guidance. And if we stepped into that role, my inspectors simply wouldn't be trained for or prepared for that. And
where would we get the compliance from? How can parents be reassured that there is some compliance?
Well, I think we provide a slightly higher level of assurance by looking at the leadership and management. So just as we do with many areas of schools' work around SEND provision, around safeguarding, among many aspects of what they do, we don't provide a sort of microscopic check on every single thing, but we do provide a higher level of assurance. And what we do in relation to leadership management will do some of that. The direct health and safety responsibility sits with the health and safety executive, who historically haven't routinely visited schools or colleges, only by exception. I mean, they may decide to change their approach, but there is another inspectorate that is set up to look specifically at health and safety.
We are about to run out of time. There has been a question, Russell, for some of the papers or so on that you've referred to today to be put online or to be made available so that people can have a look at some of your references. Can I thank you both very much? And I wish that we had longer because there are so many more questions to discuss. The next COVID-19 webinar is next Thursday, which is on the 10th of September, and this will cover the global public health lessons learnt during the pandemic and will feature Professor Devi Sridhar and Dr. David Nabarro, which will prove to be an interesting discussion as well. But thank you, everyone. And I apologize if we didn't get to your question. I tried to group them together as much as I could, but there's just too much and too many interesting questions to get through. But thank you very much to both of you, and thank you for listening.